Okay, we're going to move on here. This is a great discussion.
Good job, Ali.
We now have Dan Reinstein is going to talk about a very complex problem, blended vision.
No, actually, what's beautiful about this solution is that it applies the KISS principle. It keeps it very, very simple. Now, like most simple things, it's actually very difficult to explain. So I'm going to try and do that for you in about 10 minutes. And you know my disclosures. And I can't advance this slide, guys. Oh, there we go. Okay, we got to start again because this video is not going to work if I don't do this properly. Well, I prepared some videos to try and explain this. Now, in a normal eye, or in a perfectly focused optical system, the image on the retina is perfect, and the point light is focused exactly onto a point. There's no spherical aberration. The point spread function on the retina is excellent, and the perceived image in the brain is excellent. If, in this kind of system, you move the object forward and back, then because light is focused perfectly on a point, there is no depth of field. You completely lose focus no matter where you move outside of that retinal plane. It's what we were talking about yesterday. Bad idea to zero out the spherical aberration of an eye with cataract surgery. Now, if we were to increase spherical aberration, what happens is that the retinal image gets slightly degraded. But because of our innate neural processing systems that speak spherical aberration, it's a language of the brain, the retinal MTF, the retinal PSF stays the same. In other words, there is a range over which you can degrade the retinal image and still get a perfectly sharp perceived image. That is the way the brain is designed. Of course, if you increase the spherical aberration, you have therefore a depth of field, because anywhere you move within that range, you're still maintaining the spherical aberration control that the brain has for processing your perceived image. If you go outside of that range, of course, you'll degrade your perceptual image also. And there's plenty of evidence for this now, coming from people who are using adaptive optic systems that non-surgically induce spherical aberration to the optical path of a human, and have them test their contrast sensitivity and their depth of field. And so this is proven concept. The brain is able to filter spherical aberration. That is how it's made. And so what we're trying to do is to take advantage of this. You've seen slides like this before, slightly out of the focus of a system that has no spherical aberration, you get a lot of blurring. If you add spherical aberration, you increase edge detection. Here's an optical bench model where the defocus is being increased here up to -2. You see that without spherical aberration at -150, the letters are not discernible. But if you add spherical aberration to that same defocus, you now have edge detection. And remember, this is the retinal image, not what you perceive. Of course, even the oldest patient still has miosis during accommodation, and so the pupil effect, the pinhole effect of the pupil, is also giving you a depth of field effect. Look at the -150 column. So what we're talking about here in a nutshell is taking what would be a monovision defocus of -150 and altering it by controlling spherical aberration beneficially, using the pupil change as a depth of field device, and therefore getting a rather good retinal image, which the brain can then process to a perfectly perceived image, sharp. Now, this is really not advancing. Okay, so let's go back to the diagram. So in this system, if we were to go beyond this threshold of spherical aberration, well, that is where we're starting to indeed affect the brain perceived spherical aberration capability. And so it is about keeping the spherical aberration within a certain range, which is the range that the brain can handle. How do we know this? Well, we know this because in the 90s we were doing myopic refractive surgery, and Allah is still scared of doing above -8 because of his experience from the 90s. If you put too much spherical aberration in the eye, you really harm the visual quality of the perceived image, and you get night vision disturbances and all. And we have published studies on this, which is how we came to this realization. Of course, the ideal presbyopic solution is to have 3 diopter depth of field in the cornea, and then you can see everything from far distance all the way to near. But what we found was that we could only increase the depth of field in the cornea up by 1.5 diopters. If we try to do more, we lose contrast. And so we needed to then borrow from monovision principle and create a micro-monovision, which by its nature results in an intermediate fusion zone, because the visual acuity of both eyes is close enough in the intermediate range that you get fusion between the two sides. So this is not monovision, it's binocular vision. And I'll show you evidence in a minute. And like I said, that's completely different from monovision, where you have a near focus and a distance target, nothing in the middle. That is why monovision is not that well tolerated. I mean, it's tolerated by about 50 to 90% of patients, depending on the study you look at, because the near vision of the distance eye is very blurred, and the distance vision of the near eye is very blurred. What we're doing here is, by using spherical aberration, we're increasing the edge detection at near for the distance eye and at distance for the near eye. And so most patients confuse these two images and tolerate this micro-monovision. It's because of the increase of depth of field that the micro-monovision is tolerated. So, like I said, most simple things are simple, but when we actually think about all of the possible ways that this is working, I came up with 9 different things. We've now discussed 3 of them. In other words, the depth of field increase by changing spherical aberration and borrowing from monovision. We've talked about retinal processing, neuronal, perceptual processing to increase edge detection. Vertex centration is something which is perfectly achievable with an excimer laser because we have super accurate trackers, and so placement of this procedure is exactly on the approximation of the visual axis, which is the corneal vertex of the coaxially fixating eye. So we have a centration control which is much better than any intraocular lens until Julian Stevens comes out with the button piercing femtosecond lens that can center on the visual axis. But right now, lenses work on the visual axis. Gunter discovered that the inlays must be placed around the visual axis, not the entrance pupil. And one of the other mechanisms that's working here, which I didn't speak about at all until recently because we submitted a patent on this, and that is that we're getting a multifocal effect from the epithelium. And we learned that because we had treated a patient, actually, that George Waring had sent us. He was a NASA engineer who had had multiple procedures and had very amorphous complaints about his vision in that eye. It was hard to pin. He had very low contrast. And we found that his stromal surface was terribly irregular, even though his topography was quite regular. His epithelial profile looked like this. It looked like thin, thick rings. And that meant that he had a multifocal, like an array lens of epithelium. And we all know how good array lenses are. And so what we did was to do a transepithelial PTK, wiped out those irregularities, his epithelial profile went completely regular, and his contrast went up to high normal. So what we're doing here is producing a Z4,0 carve-out into the stroma, which gets filled by epithelium, so that the topography doesn't see it. And so it's a subsurface lenticule, which is different from what many, for example, wavelight users have experienced, which is where you push the slider too far and you get a central island because you've carved too deep and the epithelium can't compensate fully. Finally, the neural summation, the binocular elements of this. And in blended vision, as we've published in our studies, the binocular uncorrected distance visual acuity is either the same or better than the monocular vision of the distance eye, which is in contrast to monovision, where it's usually the opposite. And if you look here at 395 patients for myopia, hyperopia, and emetropia altogether, you see that 80% of them have 20/60 vision in the non-dominant eye. 92% of the distance eyes have 20/20, but when you add the eyes together, the distance vision goes up to 96% because there's fusion and there's a contribution at distance from the near eye, even though it's 20/60. And here you see practically all patients see at least the same at distance or better with binocularly than they do monocularly, which is the opposite with monovision. Another bit of evidence about fusion is that these patients uncorrected at near have stereo acuity, and they all have all patients have 400 seconds of stereo acuity, but most patients have 100 seconds of stereo acuity despite the micro-monovision. And of course, blur adaptation and blur suppression are, monovision principles, which I'm sure are working in our favor. So just quickly, the outcomes. These are the published outcomes: 136, 111, 148 patients in each of the groups. Myopia up to -850, hyperopia almost up to +6, and the emetropes. And these were all done with a handcetome, so in fact the outcomes aren't as good as we can get now with a femtosecond laser. And remember, the principle being that the dominant eye is set to plano, but it sees plano to -0.75 depth of field, and the non-dominant eye is set to 150, but it sees at distance as if it's -0.75, and at near as if it's -225, because of that 1.5 diopter depth of field. And following on from George's comments, we have 90% follow-up at 1 year, which is the FDA criteria for a good study, and these results are including enhancements. So if we look at the 20/20 J5 rates, practically all of the patients are in that bracket. If we look at 20/20 J2, then for the myopic group, 95%, hyperopic group, 77%. Remember, we're treating up to +6. If we look at the 20/20 J5 rate, that's 95%. And for the emetropes, 93% see 20/20 J2. The intermediate vision, this is a subset of patients that in a separate study that we did. Practically all patients are reading computer font in the intermediate range, but as you can see, the vision is almost 20/20 for most patients at intermediate. There's no loss of best corrected visual acuity, because of course was the criteria for developing this product. And the myopic, hyperopic, and emetropic groups, none of them showed a decrease, and in fact there were slight increases in contrast sensitivity, probably because we're optimizing the spherical aberration of the eye. So in summary, this is a treatment which corrects pure presbyopia or ametropic presbyopia with a very wide range of treatment, including cylinder. It's based on the natural language of the brain, which is spherical aberration. That's the simple part. It's not based on a weird set of aberrations, center, near, distance, far, whatever. It's not based on some weird discontinuity in the cornea. It is a totally continuous function. Of course, it can simultaneously correct the cylinder and sphere. It can be adjusted like any LASIK procedure for cylinder and sphere. It's centered exactly where you want it to be, close to the visual axis on the vertex. Minimal compromise to night vision contrast sensitivity. It's tolerated by most patients. Functional stereo acuity is maintained. There is no visual subtraction, as we see in monovision. And of course, it's done as a bilateral LASIK procedure with no alterations to your technique or your knowledge of how to manage the surgical case. And we have, a good 60 years experience in cutting flaps and putting them back and having safety. 35 million eyes already treated worldwide. Thank you.
Any comments from the panel?
So what spherical aberration are you targeting?
Because I knew that was going to be the first question, if you could put my slides back up, I prepared some supplemental slides.
In 1 minute or less.
Because that always gets asked. And you missed the bit where I said, there is no target spherical aberration in this treatment. I keep on getting asked this. Okay. There is no target spherical aberration. There's no target Q. That is a wave-like concept. This is based on control of spherical aberration in your ametropic corrections, which induce spherical aberration, or induction of spherical aberration in your emetropic. So in the myopic case, where someone comes in with a little bit of positive spherical aberration, your low correction will induce some spherical aberration and you're in the happy zone. If someone comes in, as was pointed out earlier in the panel, with very high, as Ala is worried about, if you do a high correction, you could be transferring someone into the dark zone for spherical aberration. Not good. But likewise, as someone mentioned, if you had someone who comes in with high spherical aberration, you could even do a low correction and drive them over the threshold. So the point of this software is to make sure that none of these eyes end up above threshold. That's the point. And in hyperopia, it's the same principle. And in emetropia, it's about perhaps driving the spherical aberration up slightly because it might not be enough. But that's why we do a wavefront measurement before surgery. We import the wavefront, and based on age factors, accommodation relative to the age of the patient, because it could be a little bit less or more than their age, we can actually control this spherical aberration to optimize what the brain can do to understand
what level are you
the image.
controlling for? What is your threshold that you have here?
The threshold, because I knew you were going to ask that question, I prepared a slide earlier on that. Let me just show you.
The other thing while you were looking for that slide,
It's 0.56.
0.56.
Now, that is, the number came from a 2004 publication of ours on night vision disturbances, where we noticed that when we did a wavefront guided treatment, here it is, when we did a wavefront guided treatment on patients, we found that we decreased these are the patients that had night vision problems and low contrast. We decreased their contrast sensitivity by 27%, but we increased their contrast sensitivity to normal, despite the fact that we had left them with spherical aberration. In contrast, the control group, who had no night vision disturbances after their LASIK for the same amount of preoperative myopia correction, we increased their spherical aberration, but their contrast sensitivity ratio did not change. And so this told us that it is healthy to have a certain amount of spherical aberration in the eye. And that level, we empirically from this study realized was somewhere around the 0.56, 0.6 micron level. Ask me a question I don't have a slide for.
I think we need to move on here. That is a great discussion.
I have one question, though, that I will leave you all with. In fact, I'd like Gunter to comment on a literature search that I did before I came. And this summarizes all of the camera latest iteration, ACI 7000, and talk about reproducibility of studies, because your outcomes are fantastic, but amongst these other studies that have been published with the same device, including Tomita's results, there is a loss of 2 lines in a number of studies, and including Tomita, who's arguably the most experienced implanter in the world, for myopic LASIK combined with the implant. I wondered if you could comment on that.
I don't know whether this is including the retreatments. I mean, he does the sim LASIK in most cases.
Yeah,
now
this is his paper that was published.
Yeah, but was this, I don't recall all the details in his paper, was this retreated patients or was this after the first treatment? Because of course you have a certain amount of patients where you don't hit target, and I don't know whether he retreated.
But what about the loss of lines, the lack of safety? That's not a retreatment issue.
That's best corrected, I assume.
That's loss of
I don't
2
know.
lines or more.
You'd have to ask Tomita. I can't comment on that.
It might be decentered. The retreatment
Might be
might be a
decentrations.
recentration.
Yeah.
So if any,
But Tomita only he recentered 1% of his patients, and yet 6% had more than 3 lines loss. It's 3 lines or more, which is a lot.
That's
and he's
correct.
very experienced.
I don't know. You'd have to ask him.
Just for reference, I put the blended vision results at the bottom for you, just so that you can see.
Absolutely.
Yeah.
No,
okay.
yeah,
See,
absolutely.
my point here is this, and I'll just try and be gentle about this.
I mean, well,
Putting implants into the cornea Putting implants into the cornea, as John put it, is a punishment.
Well,
Doing LASIK, you can hardly call that a punishment. It's a natural procedure that Barraquer conceived of. It's stroma on stroma. There is hardly any biological inflammation. It heals beautifully. It's stable over decades. Why are we going to combine LASIK with an excimer and then put an implant when you can do it all without an implant? That's my question.
Let's do this over the break.
I think I can answer the question. I remember one of his lectures some time ago where he had, here are some patients that started uncorrected with 2012. Very high visual acuity. And these patients, they lose 2 lines. They might end up at 2025, 2020, but still in the group of so I had patients, most of my patients were 2016. They ended up slightly between 2020, average 2022 something. So you lose lines, you have to report it, but you're still in the 2025, 2020 range.
Right.
So I think that's probably the case in this case because he had very good patients to start with.
Dan, I think you took us in another discussion here with the corneal inlay. We're still discussing the...
Yeah, sorry.
Now, back to the high myopic treatment, because I'm still not convinced, and I will never be convinced that you can show me that you can show me a patient who had a LASIK for -10 or -12, and you can have a cornea that is prolate over the 7 millimeter pupil, and that he can have the same quality of vision after LASIK that he can have after a phakic intraocular lens. I know in North America, I'm not sure in the UK, in North America the big phakic IOL are not a big thing, but if you know, maybe they don't know what they are missing.
Well, Ale, I'm not going to argue with that. Obviously, an intraocular lens is not... is not going to affect night vision as much as a corneal treatment where you're having to do contortions, Chinese gymnast-style contortions to make the spherical aberration stay within normal range. There's no argument there. But let's talk in context. A patient who's 28 years old, or 38 years old, or 48 years old, with a choice of having a procedure that is extraocular, takes 5 minutes and heals in 3 hours and is adjustable, versus an intraocular procedure with all of the extremely rare but possible complications of an intraocular procedure and the long-term follow-up required with respect to lens changes, cataract formation, and in these long eyes, retinal detachment following the cataract surgery because of the complication of the phakic IOL. On balance, I think patients would rather we came up with a solution that was extraocular. They would rather we did that. And our experience with this blended vision profile is that the spherical aberration control is so good. And I have to say, I think that the NIDEX system is extremely impressive in terms of its spherical aberration control. Your published results are phenomenal. And I am convinced that you could use your profile to treat very high myopia and not have problems with night vision in your patients because of the way that I've seen your data published.
Dan, let me set you up here. If we weren't such good friends, I wouldn't do this. How much intraocular IOL surgery do you do?
No, I don't do any.
How much is done in your practice?
We refer to our intraocular surgeon because of the ability to treat on the excimer. I would say 15 patients a year.
15 patients a year.
It's not much. But realize that we're treating myopia up to -13 and 14 quite comfortably. And by doing that, think about this. No, look, if you thought that I was not obsessive about safety, you haven't been listening to my lectures. We're doing it safely. It sounds like a joke, but if you look at the science, you'll find that it's not a joke. We're perhaps a little bit ahead of the thought curve that was developed from our experience in the 90s, which was abominable. If If you look at my spherical aberration increase that I demonstrated yesterday for the Summit 5 millimeter -6, the patient, his spherical aberration was pouring out of his ears just for a -6 correction. That is history, and you need to lock your minds into thinking about corneal surgery in a different way. Neidig, Schwind, and the Mel-80 are doing extraordinary jobs of controlling spherical aberration now. And it is a different paradigm. We are not just thinking about what we used to do. So, George, if you're trying to say, what do you know about intraocular surgery as you don't do it?
Well, I wasn't going to say it that way, Dan.
I mean, quite frankly, I don't do it because I don't consider doing 15 cases a year to be an appropriate level of expertise to offer a patient a treatment. And I stick to what I'm an expert at, and when I think that a patient is not appropriate for what I can offer, I send them to somebody else who will take care of them properly.
Good judgment.
Okay, let's move on. We learned so much.
I'll see you outside, George. I'm going to get my gloves on here.